Paris is not only the city of light, love and culture, but it's also the home to the biggest interventional cardiology meeting, the Paris Course on Revascularization, or the PCR. Last week, the meeting was back in person after 2 years of COVID-imposed virtual attendance. This year, there were 8,000 attendees inside the Palais du Congrès, tens of sessions, live cases and industry stands. This edition of Euro PCR celebrates 30 years of radial catheterization and 20 years of transcatheter aortic valve implantation, TAVI. I had the chance to attend the meeting in person, meet the experts, present my cases, attend some sessions, and I'm here bringing to the CardioBuzz audience who couldn't make it to the conference the hot topics and the late-breaking clinical trials from Paris. Out of 4 days, packed with trials, live cases, and new products, I will present 7 of the most relevant gadgets and studies that I think will change the way we practice cardiac catheterization in the future, and they are best called the Cathlab of tomorrow. So let's start. I am Hussein Heshmat, Professor of Cardiology and Interventional Cardiologist, and welcome to this episode of CardioBuzz. When we hear the word robot, what comes to our mind is those human-like metallic bodies with shuffling legs and shuffling arms walking around, either serving humans, entertaining humans, or even killing humans, as in the Terminator movie. But in reality, robots are just computers that are connected to mechanical platforms, and these systems can outperform the human capacity when it comes to speed, precision, and stamina. In Euro PCR, robotic angioplasty was presented as a live case in the main arena. The operator was not inside the Cathlab room, but he was outside the room, in front of a control box. He was controlling the procedure, advancing wires, advancing balloons, positioning stents, with a joystick. Only the nurse scrubs with the patient inside the room, and her job is to feed the machine with the supplies and take them out from the machine and the patient. This technology promises not only to cut the radiation exposure to the doctors, reduce their physical strain and spine problems from standing wearing heavy lead aprons, but it also promises to improve the precision, because the computer and the machine can control stent and balloon positioning in 1 millimeter accuracy. Also, procedures can be performed in underserved areas theoretically by experienced physicians remotely. However, the system has some limitations. It cancels any tactile feeling by the doctor's hand, and this can be quite dangerous and can lead to some dissections, as we've seen in one of the cases. It can only control 2 wires, and it's limited in size when it comes to the guide catheter. And of course, cost is another story. In my opinion, this technology will stay, and in the future we'll see it coming to more complex interventions, not only for simple procedures. The last thing that we want when operating inside the cath lab is a surprise that we were not prepared for. It would be great if we can practice the procedure before we start actually on the patient. How can we do that? The answer is simulation. And this has gone a long way. Now the patient images, either from angiography or CT scan, can be loaded into the computer. The software will simulate the patient's vessels and valves. Then we can do the procedure several times on screen. We'll have time to plan at ease, expect any troubleshooting, and come up with solutions beforehand. This technology is already available, the screen simulators, and it can give sense of the procedure to physicians who are not familiar with the procedure. In the conference, there was one step further. Now there are companies that can 3D print the individual's unique anatomy of the patient, for example, who needs an aortic valve implantation. So in addition to visual reality, to avatars of remote proctors, there will be a 3D printed model of the patient's aorta, brachiocephalic vessels, femoral artery. Without touching the patient, the operator can get the tactile feeling of this patient before doing the procedure. We expect that this will improve the patient's safety and allow the procedure to be done by a larger number of physicians. If this also goes into the coronary arena, then cardiac cath procedures will become even safer and easier. How many times did your patient come to you after the cardiac cath complaining that he's worried about the foreign body stent in his coronary vessel? Fixing the coronary stenosis without a permanent implant is always welcome, provided that this solution is durable and does not fail early. Drug-coated balloons dilate the lesion and can deliver the drug without leaving a permanent implant or scaffold inside. When used properly in the right situation, they can provide results that are similar and sometimes even better than stents, especially in the smaller vessels. I'm personally a regular user of this technology since 2014, and I must admit their outcome is great. In Euro PCR, there were several registries presented with different balloon vendors and brands. We have now, in addition to Sequin Please, which is a paclitaxel releasing balloon. We also have sirolimus-based solutions like the Magic Touch and the Solution. The studies that were presented coming from Europe and from Asia on the sirolimus-based drug-coated balloons showed excellent results, very good success rates, similar to those seen with the best drug-eluting stents. I personally expect the future to have fewer stents and more zero-footprint solution like drug-coated balloons. Tell me in the comments, what do you think of drug-eluting balloons? Do you insist on using a stent, or you can use drug-eluting balloons in some situations? We know that by measuring coronary flow and pressures, the FFR, we can diagnose which lesion needs to be treated and how effective will the treatment be in regaining the normal vessel hemodynamics. Traditionally, we can do that invasively by placing the sensor wire inside the coronary vessel and measuring the pressure distal and proximal to the lesion. It can tell us whether the disease is focal or diffuse. But these wires are not very steerable, they need calibration, and they add extra time and extra cost to the procedure. Now we have less invasive alternative. Instead of FFR, we have a QFR. This is a software that analyzes the angiographic images taken inside the cath lab. They utilize the images and calculate the pressure without having a wire, just from the images and the video loops. The software also calculates the length of the lesion, tells us whether it's focal or diffuse, and identifies the significance of each lesion, helping to predict the expected improvement with fixing that lesion. This technology now is mature. It has been benchmarked against the wire-based FFR. Studies that came from the Far East, China and Europe showed that QFR was superior to the ordinary angiography. It's now called virtual angiography. And it changed the decision in 1/4 of the cases compared to angiography. And surprisingly, most of the changes were towards less stent implantation. I'm personally starting to use this tool. I find it very useful when the wire-based solutions are not available and when we are short of time. I expect a good future for QFR personally. So write down your opinion in the comments. What do you think of this technology and its utilization? Transcatheter aortic valve replacement implantation, TAVI, is now the standard for many patients with severe aortic stenosis. This therapy is less invasive and especially fits the elderly, frail, and patients with high surgical risk. However, we thought of durability as an issue for TAVI because patients may need another replacement within few years down the line because the prosthetic valve degenerates because it's biologic. This year was celebrating 20 years of TAVI. I enjoyed the discussions about TAVR versus SAVR. SAVR is the surgical aortic valve replacement. I'm glad that we're moving away from turf wars and coming into teamworks, where cardiologists and cardiac surgeons are working together for each individual patient to decide what is the best way to treat. Is it a transcatheter or a surgical implantation, whether this is a first implant or a redo? The published data showed comparable durability of TAVR and SAVR, with even slight durability for TAVR compared to SAVR. We're seeing more valves coming to the arena with improvement in coronary access using the commissural alignment, reduction of conduction defects with the cusp overlap techniques, more options for repeat procedures valve in valve, whether the first valve was a surgical valve or it was a percutaneous valve. We expect the future to be less invasive with more TAVRs compared to SAVRs, but we also expect the surgeons to be working inside the cath lab alongside the cardiologist, not only in the operating room. I do 80% of my cath procedures from the radial and 20% from the femoral, the groin. We know that radial access is associated with less bleeding, more convenience, and even less mortality. In the last few years, I've been personally moving from the standard radial in the wrist to the distal radial access from the snuff box. I find it more convenient for patients who can move the wrist and the hand shortly after the procedure. It's also easier to compress because it's very superficial and it's associated with less radial artery occlusion than the proximal wrist access, or at least that's what we originally thought. In this Euro PCR, the DISCO trial was presented. That was a multi-center trial of 1,300 patients who were randomized either to proximal radial, the standard transradial, versus the distal radial axis, the snuff box. The study found a 0.3% radial occlusion with the snuff box versus 0.9% occlusion with the standard radial axis. Although the numbers are better with the distal radial, the difference was not statistically significant. This could be due to the low rates of occlusion in both arms and to the high experience of operators in patent hemostasis in both aspects, in the distal and the proximal. Patent hemostasis is known to prevent radial occlusion. To me, this can slightly temper down the general enthusiasm for snuff box, but honestly, I will still use it for the patient's convenience and for the nursing relief. Tell me your opinion in the comments. What do you think of radial access in general and of distal radial in particular? We're still in the access domain, and because Euro PCR is celebrating 30 years of radial access, I chose this as the most important trial because it's a trial that touches patients, nurses, and doctors. Radial access hemostasis is important for everyone, and there is no clear agreement on what's the best compression modality or duration. In Euro PCR, there was a nice study from the UK that was presented. This was a study that randomized 2,400 patients with radial catheterization into 3 ways of compression. The conventional dressing with TR band compression for 2 hours, that was one arm. The second arm was the conventional dressing with TR band for 1 hour. The third arm was a hemostatic dressing called the stat seal with 1 hour of TR band compression. Stat seal is a sterile absorbent and a bio-occlusive dressing. It has a hydrophilic polymer that dehydrates blood and absorbs exudate, stacking blood solids to form a seal on the puncture site. It also has some potassium ferrate that agglomerates the solids and proteins together, adhering to the seal, to the wound, to stop bleeding and oozing. It should be applied before the sheath is removed while the TR band is on top. And the dressing should ideally remain in place for 1 to 3 days. The primary outcome of the trial, which was failure of compression, occurred in 62% with just 1 hour compression, standard dressing, 50% with 2 hour compression, and only 5.2% with 1 hour stat seal compression. Honestly, I've never tried this stat seal before, but if it fulfills the promise, then it will make radial procedures easier for the nurses, for the patients. It would allow for earlier discharge, faster turnover of patient, reduction of hospital costs, because you can achieve hemostasis with just 1 hour of compression. There are also similar solutions that can be used not only for the radial but also for the femoral puncture. I'm adding a link to the manufacturer in the description, and there's also a recently published trial in JACC intervention that came to the same conclusion. That was all for this week. Thank you for watching this episode. If you like the content, please hit the like button. Check the links in the description. Subscribe to the channel. Browse the previous episode and activate the bell to get notified with the coming episodes. And see you next week.